Welcome and thank you for joining us for this webinar, 2018 MIPS, A Basic Introduction. For those of you who may not be familiar with Acevedo Consulting, I'm going to tell you a little bit about our firm. We're a healthcare consulting firm. We assist clients with chart audits, compliance and HIPAA programs, credentialing, and things like education and appeal assistance when there have been audits from a payer. I'm your speaker today. My name is Catherine Becker, and I'm one of the consultants here. I do a lot of the work in the payment programs, such as MIPS, so I will be with you today and hopefully answering some of the questions that you may have about this program. Just a small disclaimer, and that is that all of this information is current as of today. With the MIPS program, particularly because it is new for Medicare, the information does continue to evolve throughout the year. So I would tell you to make sure that you are checking in with the CMS website for this, which is qpp.cms.gov, because we will see them continue to put out additional guidance throughout the year, much the way they did in 2017. So just to get us started, this is what the Merit-Based Incentive Payment System, otherwise known as MIPS, is going to look like for 2018. You will be scored on 4 different performance categories. The first is the Advancing Care Information category, which we used to know as Meaningful Use, and that will be worth 25 points. We also have the Quality category, which used to be called PQRS, and that will be worth 50 points. And then we have the Cost category, and some of you may or may not be familiar with this. There used to be what was called the Value-Based Payment Modifier Program, and how you were scored under that program was using what was called the Quality Resource and Use Report. And so that was not included for 2017, but it is back for 2018. But they're still tweaking this part of the program, so it will only be worth 10 points for 2018, but that will go up in future years. And then finally, the one part of MIPS that did not exist before is the Practice Improvement category, and that will be worth 15 points. The performance periods for 2018 are a little bit different than what we saw in 2017. In 2017, you got to pick your own pace, whereas for 2018, CMS has gone ahead and designated what the performance periods will be for each category. For quality and cost, it will be a full year, which means that you'll have to be collecting all of your quality data for the entire year. For cost is not much of a concern for you because that is all collected from your claims data. So there's nothing that you have to be doing from a data gathering perspective as it relates to cost. And then the Advancing Care Information and Improvement activity will both be a 90-day period, and you do not have to choose the same 90-day period for those 2 categories. All right, just to give you a little look at MIPS, these are the years and how they will line up with the different payment adjustment schedules. Like we saw in the PQRS and Meaningful Use program, you will have your performance year, then there will be a gap year, and then you will see the payment adjustment for that. So for 2017, the year we just finished up, you will see the adjustments in 2019. For 2018 as our performance year, we will not see those payment adjustments until 2020. And the reason that there's a gap year is because CMS always gives you through March of the following year to attest to all of your data. And then it takes them several months to go through everyone's data to see whether or not they've successfully met all of the requirements to determine who's going to get a payment adjustment and what that payment adjustment will be. So as you can see here, for 2020, our expected payment adjustments are anywhere from -5% all the way up to a +5%. So that can be a nice little payment adjustment if you are getting it to the positive, but it can also hurt you quite a bit if you're choosing just not to participate. One thing that was changed between the previous programs and MIPS is now you can be scored based on how well you perform. In the past, it was all pass or fail. It didn't matter how hard you tried. If you missed it by even a little bit, you got the same penalty as people who never even attempted the programs. So under MIPS, what they've done is there will now be a sliding scale, and they will pick a performance threshold, and that will be the baseline. If you can hit the performance threshold, you will have a neutral payment adjustment, which means they just won't touch your payments. If you score above that, you can start earning a positive payment adjustments, and then if you score below it, you can potentially have negative payment adjustments. And again, how far positive or negative will depend on how far you are from that performance threshold. All right, just so everyone is clear who our eligible providers are under MIPS for 2017 and 2018, the list of providers is physicians, physician assistants, nurse practitioners, clinical nurse specialists, and nurse anesthetists. Starting in 2019, it is projected that we will add pretty much all other providers who are eligible to bill Medicare. So if you have any of these providers, such as an audiologist, a social worker, something of that nature, you may want to start preparing yourselves now because they are projected to be back into the program in 2019. But as far as 2018 is concerned, they are not required to attest. A special note, non-patient facing clinicians. These are clinicians who bill 100 or fewer patient-facing encounters, including Medicare telehealth services during the determination period, are considered non-patient facing. And groups are considered non-patient facing if more than 75% of its clinicians have 100 or fewer patient-facing encounters, including those Medicare telehealth services. These clinicians are required to participate in MIPS. It's just that they may have some alternative reporting requirements through some of these categories, which I will mention as we go. So that's just something to keep in mind. You may be wondering to yourself if anyone is exempt, and there are a couple possible exceptions. One is low volume threshold providers, which I'll break down in more detail for you in just a moment. We also have providers who are in their first year of practice. And when I say first year of practice, I mean they are brand new to the Medicare program. They've never had a Medicare number before. This is not just that they are new to your practice. And then we have participants in an advanced alternative payment model, such as an ACO. For these APMs, there are a bunch of requirements, such as the APM that you're participating in must be a risk-bearing ACO, or it could be a patient-centered medical home, something of that nature. But at least a certain portion of your revenue has to be going through that program. And as I said, the program also must be risk-bearing, which means that they can lose money. A lot of those programs, as they were initially set up, only have positive impacts for the practices who participate. So if you think that you participate in one that may qualify you for this exemption, please talk to your organization to make sure that they are in fact a qualified APM that would alleviate you of your responsibilities to report under MIPS. So I told you I would explain low volume threshold a little bit more. That is anybody who sees less than 200 Medicare patients in a year or bills Medicare less than $90,000 in a year. This is up from 2017, so they did raise this up, but depending on where you are, this still may not have made a big difference in your area. So you have a couple of different reporting options when it comes to MIPS. You can report as an individual or as a group. What it means is if you choose to report as a group, that everyone under the tax ID will report their data together. So essentially all the scores get dumped into one pot, and then one payment adjustment will be applied to the entire group. One thing that is new for 2018 is the possibility of virtual groups. This is where you can join together with other tax IDs to form what's called a virtual group and report your data together. The one trick to this is that you must register to participate by December 31st of the year before the reporting period. So if you did not choose this option by December 31st of 2017, you cannot use it for 2018, but it may be something that you want to keep in mind for 2019. And as I said, a virtual group is a combination of 2 or more tax IDs, and this can be comprised of a solo practitioner up to groups of 10 under a tax ID that can join together. And if you're choosing this option, everybody under the tax ID must participate, and you can only join one virtual group. And as I said, you have to decide by December 31st of the year prior to the formance period. And the other thing to think about is once you've elected to participate as a virtual group, you cannot undo that election. So you want to think about this before you join a virtual group and really do your due diligence before signing on to participate with another group and make sure that this is somebody that you want to be tied to from a scoring perspective. All right, so now we're going to get into the 4 scored categories. We have quality, which is worth 50 points, down 10 points from 2017. And here you have to report on 6 measures or participate in a specialty measure set. One of your measures should be outcome-based, but if you cannot find one that is outcome-based in your specialty, then you just need to choose another high priority measure. CMS has created suggested specialty sets, but you are not required to use these if you feel like there are other measures you like better. And if you choose to use a specialty set, some of them have a lot of measures underneath them. You only have to choose 6. So if you look at a specialty set and it has, say, 18 measures, you only have to go in and choose 6 of those 18. You're not required to do everything that appears under that specialty set. Under that same vein, if you go open a specialty set and it only has 5 measures, then you are free to use just that specialty set, and you don't have to worry about going to find additional measures if CMS has said that that's all they see for that particular specialty. All right, so now I have a couple of slides here that show the different specialties that are available. We've got allergy, cardiology, diagnostic radiology, emergency medicine, hospitalist, internal medicine, podiatry, optometry, pediatrics, rheumatology. So you can see that there are quite a few specialty sets that are out there, but I will tell you it's still not a perfect list that includes all specialties. One I continue to wait for is palliative care. We work with a lot of palliative care providers here, and it's something that I would love to see show up here because they are such a special niche within healthcare. And as of right now, they really could use some assistance in this quality category because some of them really do struggle to find measures that are applicable to their specialty and the way that they work. All right, so if you truly cannot find 6 measures that you're eligible for, then you can report less than 6 measures. You just want to be aware that CMS has a process that they run on your claims data to determine whether or not you had other measures that you were eligible for. Because you are eligible for measures based on CPT codes or diagnosis codes. So CMS can run your claims data to see if you had other measures that you were eligible for. And so that's something that you have to be aware of. You may only like 4 measures, but that doesn't mean that those are the only measures that you are eligible for. So you want to keep that in mind. And also, if you make your determination early in the year, how many measures you're eligible for, you may want to make sure that you're keeping that in mind as the year progresses. So for instance, sometimes I will have let's go back to the palliative care providers who only see patients in the hospital. The hospital tends not to have a lot of measures available, so it's very possible that they could only find a couple of measures that they're eligible for. But let's say 6 months from now, they start seeing patients in their homes or in the office setting. That may open up more measures that they are now eligible for. So you just want to be careful if you're making these decisions early in the year that you are not eligible for 6 measures, that you keep that in mind in case something about the way that you practice changes as the year progresses. CMS will take your performance rate in the quality category, and then they're going to compare it to a national benchmark. This is different than what we saw under PQRS. So just because I go out and get a 95% on a measure does not mean that I will get 95% of the points that are available for that particular measure. CMS will then take my 95% and compare it against the benchmark to see how I performed compared to my peers, and I will be adjusted accordingly. So if it's a measure that people did phenomenally well on, 95% may not be all that great if everyone else was getting 100% on that particular measure. The benchmarks are established by looking at the performance rate for the same measure 2 years prior. So for 2018, they'll be looking at the benchmarks that were set in 2016. Each measure will be worth 10 possible points, and you must report on at least 60% of the data to earn more than the minimum, which means the minimum amount of points if you have a group that is 15 providers or fewer is 3 points. So if I only report on 50% of my patients for measure, the most I can get is 3 points. If I exceed that 60% data completeness threshold, then I can earn up to 10 points per measure. So that's what that means, is you have to exceed at least that 60% in order to get more than the minimum. If you have a group that is larger than 15 providers, then the minimum is 1 point if you don't exceed that 60% threshold. So you're going to want to check your measures that you're choosing in advance to see what kind of performance rate you might need to achieve the most amount of points possible. There are topped out measures. CMS is going to start phasing these measures out after they've been topped out for 2 consecutive years, and then the measure will be phased out over a 4-year period. These measures will only be worth 7 points in their first year of being phased out. So quality improvement is another thing that they've added for 2018, and under this, providers can earn up to 10 points for quality performance improvement from year to year. And what level of improvement is required for the bonus has not yet been defined, but it is something for you to think about when you're choosing your measures and whether or not you have the ability to improve. Now we'll move to our next category, which is the advancing care information category, again worth 25 points. And as I said earlier, this is what you would formerly have known as meaningful use. Here, the providers must earn a base score of 50 points, and then they have the ability to earn additional points through performance measures, and they can also get bonus credit through things such as reporting to a public health or a clinical data registry. You can have this category reweighted under 2 particular circumstances. But you should know that just not having an EHR is not sufficient to have these categories reweighted. So you can have the category reweighted due to hardship, and the examples for hardship are insufficient internet connectivity. You should know if you're here in the state of Florida, we do not have any areas that qualify for insufficient internet connectivity. The next one is extreme and uncontrollable circumstances. This might be things like the hurricanes we experienced in the last year, or if you were out in California, the wildfires that occurred. And then we have lack of control over the availability of certified EHR technology. And this might be if you are an employed provider and you are in a situation where you cannot go out and get certified EHR technology on your own. You're working someplace where all they provide to you is, you can only work on paper records, or you have a non-certified EHR. So you might be able to apply for this. If you think you need to be reweighted based on one of these, you do have to apply for it, and you should keep any documentation to support your hardship. The other reason that you can be reweighted is based on a provider type. And if you're any one of these providers, CMS will automatically reweight the category for you if you do not report any ACI data. So those who qualify for this are ambulatory surgical center-based clinicians, which is new for 2018, hospital-based physicians, physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, and clinicians who lack face-to-face interactions with patients. So there are some new things for 2018. There's now a significant hardship exception for MIPS eligible clinicians in small practices, which, as I've said, is 15 or fewer clinicians. They have not fully defined that yet, so we'll see what it is they consider, whether or not if you're just in one of those practices, you can automatically apply for it, or if there's something else that you need to show in order to qualify for that. As I said, they've made a new exception for ambulatory surgical center-based clinicians. And we also now have a new exception for MIPS eligible clinicians whose EHRs were decertified. They've also revised the definition of hospital-based to include off-campus outpatient hospital, otherwise known as place of service 19. There are 2 different tracks that you can follow under the advancing care information category. We have the advancing care information measures, which is technology certified to the 2015 edition, or using a combination of technologies from the 2014 and 2015 editions that support these measures. Otherwise, we have the transition measures, and people can use these for if you're using technology certified to the 2015 edition or to the 2014 edition, or using a combination of the 2. And I will tell you, every system that I have seen thus far is using the transition measures because of the fact that it so closely mirrors the meaningful use measures. So we will see how that goes. So here is just a quick overview for you of what it looks like if you're using the advancing care information measures. You have the top box here is what you need to achieve for the base score. You have to have had a security risk analysis, which is required under HIPAA. You have to have at least 1 e-prescribe. You have to provide at least 1 patient electronic access. You have to send at least 1 summary of care and request or accept 1 summary of care. If you do those things, you will automatically achieve 50% of your total score. And then from there, you can add points to your score by using the measures that are listed for performance scores. And then if on top of that, you can also add bonus points to your score by using one of the public health and clinical data registries listed under the requirements for bonus scores. Those are worth up to 5 points. And then you'll also see reporting certain improvement activities using certified EHR technology, which can get you an additional 10 points. Here is what we have for the transition measures. And as I said, this is the one that is the most popular at this point because of the fact that it mirrors meaningful use. So I think some of the EHRs are still trying to figure out some of the new measures that are listed under the regular Advancing Care Information track. So here, to get your base score, you still need to have a security risk analysis. You have to have at least one e-prescribe. You have to provide one patient access and have one health information exchange. If you do all of those things, you will automatically get those 50% of your base score. And then from there, you can add points to your score using the performance measures. And you'll notice if you add up all of these points that you can get well over 100 points. And CMS did that on purpose because the providers have argued that the measures were too hard, particularly like things for view, download, or transmit, which requires your patients to go in and get their records. If you have patients who generally don't care and don't want to go in, that's a really hard measure to achieve. I generally don't see people get more than maybe a 20% on that view, download, or transmit. So CMS created a lot of point opportunities within these measures so that if you have a measure that just doesn't work for you, you can ignore it and still get a great score. So that's why you'll see that if you're doing the math along with me, that this can add up to well above 100%. Here, the bonus score you can get through syndromic surveillance reporting or specialized registry reporting is 5 points, or again, reporting certain improvement activities that use certified EHR technology. And that we will get to when we talk about the improvement activity category in just a moment. Here, your score is what it is. So if I get an 85% on a measure, you just look at this little chart here, and that will translate to me getting 9 points. There are no benchmarks or anything like that here. It's strictly you're going to get based on your own performance. And this is for any of the numerator and denominator measures. So for our bonus, as I said, providers can receive an additional 10% for participating in certain clinical improvement activities using their certified EHR technology. So examples of those would be 24/7 access, which means that your providers have access to their EMR 24/7, which in this day and age, most practices do. So that's sort of a gimme. So if you choose that as one of your improvement activities, you can get an additional 10 points in this Advancing Care Information category as well. For 2018, they've also added a 10-point bonus that is available for using 2015 edition certified EHR technology only. Originally, 2017 was supposed to be the last year that you could use 2014 technology, but given all of the changes and the delays in the programs and the cost that's associated with moving from one version of the technologies to the next, CMS has allowed providers to continue to use 2014 technology, but they will offer you a bonus if you are using 2015 edition solely. All right, so getting to that category, we talked about the practice improvement. This is the one that did not previously exist. This is going to be worth 15% of your total MIPS score. You are going to attest that you completed up to 4 improvement activities for a minimum of 90 days, but groups who have less than 15 participants only have to do up to 2 activities. So for groups of more than 15, medium weight activities are worth 10 points, and each high weighted activity is worth 20 points. And you need to get 40 points in total, which means that you could do up to 4 medium weight activities. You could do 1 high weight and 2 medium weight activities, or you could do 2 high weight activities. For groups of 15 or less and non-patient facing clinicians, because remember, we are going to have exceptions for those, you only have to do, again, 40 points. But here, each medium weight activity is worth 20 points and a high weight activity is worth 40. So you either have to do 2 medium weight activities or 1 high weight activity. So some example of approved activities are things like registration in the prescription drug monitoring program, which is a medium weight activity, or we have collection and follow-up on patient experience, which is a high activity. And this could be, doing surveys with your patients and following up on the results. We've got depression screening, engagement of new Medicaid patients and follow-up, and use of telehealth. And you'll see that each one shows what it's weighted at. And there are over 100 approved activities, so there's certainly a lot to choose from. All right, looking forward to cost in 2018. As I said, this was not included for 2017. Because they were retooling it. There were a lot more things that were included under your QRUR when this was a value-based payment modifier program, but CMS is trying to tweak it to make it more applicable to providers. So for this year, because they wanted to bring it back even though they're not completely done with it, they will only be scoring you on two different components. One is the Medicare spending per beneficiary, and the other is total per capita cost. So what they'll do here is they will add your score up in these two categories and give you the average. Otherwise, if you only obtain a score in one category, that will become your total cost score. So Medicare spending per beneficiary 2018 is an episode that includes all Medicare Part A and Part B claims falling in the episode window. And that episode window starts 3 days prior to a hospital admission and goes through 30 days after the hospital discharge. And here your patients will be risk adjusted. The total per capita cost for all attributed beneficiaries is a payment standardized, annualized, risk-adjusted, and specialty-adjusted measure that will evaluate the overall cost of care provided to beneficiaries attributed to clinicians as identified by a unique tax ID or an NPI identifier. And this measure can be reported at the TIN or the TIN NPI level. So what this means is it's going to look at the patients who have been attributed to you. And for those of you who have seen a QRUR in the past, you know that patients are attributed based on the plurality of care that they receive. Generally, Medicare will try to attribute the provider to their primary care provider, but as we all know, not all patients see a primary care. So what happens from there is if they cannot find a primary care provider to attribute the patient to, they will get attributed to the provider who sees them the most regardless of specialty. So if I am a patient who has diabetes and I'm seeing my endocrinologist the most during the year, that may be the provider that I am attributed to, regardless of the fact that they are not actually my primary care provider. All right, so for this year, and we are looking at a performance threshold of 15 points. In 2017, the threshold was just 3 points for 2017. And that was because CMS had provided the flexibility and said, as long as you report one piece of data, we will not give you the penalty. So for 2018, they've bumped it up, and now you must achieve at least 15 points. But as you'll recall, when I was giving you those point breakdowns, the improvement activity category is worth 15 points on its own. So it is possible for you just to report that category alone and hit that performance threshold. So it's up to you how much or how little you participate, as long as you are getting those 15 points to try to avoid the payment adjustment. There are some additional small practice considerations for 15 or fewer clinicians. There's going to be 5 bonus points added to the final score of small practices. And then providers in these categories will continue to get 3 points for measures where they fail to meet data completeness, which, as I mentioned earlier, was 60%, whereas the providers in the large groups will only receive 1 point for the measure. And as I said earlier, there's a new hardship exception for the performance category. There's also a complex patients bonus that was added for 2018. Providers can earn up to 5 bonus points for the treatment of complex patients, and this is based on the combination of hierarchical condition categories, otherwise known as HCCs, and the number of dually eligible patients treated. And CMS is doing that because they want to reward practices who are taking care of complex patients. They don't want you to be dumping those patients in order to do better under these programs. All right, so that's going to wrap it up for us for now. I'm glad that you could join us to go over this brief overview of MIPS for 2018. I'd like for you to think about your plan for 2018 and get it together. I know a lot of people tend to put it off, but as we've talked about, quality is in it for the entire year for 2018. So if you're just listening to this webinar now, we've already been into the year for about 6 weeks at the time of recording. So you've already missed some opportunities to gather data. And the longer that you wait, it gets that much harder to try and to catch up. But there's also a lot of strategy that goes into MIPS that is different from other programs that we've had in the past, deciding whether to report as individual or group, having to learn how to use the software and the technology and trying to keep up with it. We work with a lot of clients to help them get set up for these programs, and it's not always easy. I have a large group that I work with where their EMR decided to partner with a registry that was just going to help pull everything from their system. And we thought, well, that's phenomenal. It's going to be great, and they're not going to have to worry about a thing. But it is 6 weeks into 2018, and we are still playing with their data from 2017 because the registry was not calculating it correctly as it was being pulled out of the EHR. So it takes oversight. You need to have people who can help you watch and cheerlead to make sure that things are happening appropriately, because sometimes providers just get tired and they stop clicking, and you don't want to find that out at the end of a year that you don't have good data because nobody was watching to see that people were actually doing what they were supposed to be doing. But you also have to look at what's most strategic for your practice, which are the best measures to pick based on the way that you work. Because sometimes, especially if you're going to choose a group option, it may be to help cover providers who don't work for you as often, or who are working in a setting where it's hard for them to find 6 individual measures on their own. So there are a lot of different things that go into this. It's not just a straightforward data collection, and there may be things that you need to think about to do the best you can under these programs, but also doing it smartly so that you're not creating additional work for yourselves. If you have any questions, if you think that there's you'd like for us to assist you with your work in the MIPS programs, feel free to contact us. We have our contact information on the screen. We have our website listed, and if you would like to ask any questions, feel free to reach out to us at that info@acevedoconsulting.com. Thank you for joining us.